Hi, everyone. This is Joelle from Kicking Cancer's Ass at the 2026 UCSF Rise Up for Breast Cancer and Women's Reproductive Health. And this is Andrea De Censi. Andrea, I believe, is the force behind the concept of baby tamoxifen.
I am a medical oncologist by training, and actually my most important job is treating patients with cancer. But my passion has always been prevention, because there's nothing like to see patients with advanced disease to understand the importance of prevention. And I always thought that why, given the success in cardiovascular medicine of prevention, when you treat high cholesterol or you treat hypertension and you have such a benefit in reducing the clinical event, which is myocardial infarction or stroke, why isn't the same in oncology? The tamoxifen prevention trial translated the dose from the treatment setting to the prevention setting. But the population is different, and we thought that the dose was too high. We thought that at that time the minimal effective dose of the drug was not clearly established, and now the FDA is mandating to the pharmaceutical companies to identify the minimal effective dose before the registration, because the majority of cancer drugs are registered at the dose which is intolerable for the majority of women and cause a lot of clinical and financial toxicity. So that's why we started investigate the minimal effective dose, and we did the first trial on cholesterol, because tamoxifen modulates cholesterol, and IGF-1. So I like simple things that can be translated and everybody can understand. And so we showed that 5 milligram, 1/4 of the standard dose, was equally effective in modulating these biomarkers. And so we went on with a study in the pre-surgical setting, in a window study, and showed that the lowest dose was non-inferior to the standard dose in reducing breast cancer proliferation. And then we did the phase 3 trial, of course, all funded by non-profit organizations, because the drug is out of patent. And so for the benefit of women, for their quality of life, for the reduction of serious adverse events like endometrial cancer, venous thrombosis events, we did this phase 3 trial comparing 5 milligram with placebo and showed the same risk reduction, 50%, with no increased risk of serious adverse events, just the same quality of life, maybe half extra hot flash per day.
It actually begs one to question why we don't use the lower dose as the starting point. Because I think your panel today said 30 to 50% of women in the clinical setting, they've had cancer, were using tamoxifen clinically to treat, can't tolerate, and don't stay on it. So why don't they start with the low?
The people always claim about the evidence. And what we did is a trial in women with DCIS or at-risk lesions, not a study in women with invasive breast cancer. So now the study has been done in the United States with the support of the NCI, and the recruitment was very fast, because there is a huge interest in the community to look at this lower dose also in the adjuvant setting. So, but what I do in my clinical practice, many women come to me just because they know of this data, and they say, I cannot tolerate this dose. What can I do? My oncologists say, this is the protocol. You either take it or you jump from the window. And I said, well, there is a third option, that is to lower the dose. We know we don't have the proof that it will be efficacious in the adjuvant setting, but the data that we have are very, promising. And so you better go for a lower dose, and they are happy because the majority of them tolerate the dose, and it's better than interrupting, because so that is, but we are looking forward to seeing this new data when they will come in the adjuvant setting. Speaking of low-risk breast cancer, not, of course, the high risk where you may need additional treatments like CDK4/6 inhibitors or even chemotherapy. But
I mean, one of the things I try to share with everyone who listens to Kicking Cancer's Ass is that cancer is a class of diseases. And even within breast cancer, there's, I calculated, at least 140 varieties. And that doesn't include how aggressive each particular tumor is. So it's really an N of one. And I think your point is, if tamoxifen is prescribed in the adjuvant, we're getting the research, but if a patient can't tolerate it, it shouldn't be all or nothing, jump out a window. It's, okay, this is the prescribed, it's not tolerable, let's do the baby tamoxifen, get some or maybe all of the benefit, and be able to sleep at night